Yes, sir.
Yeah. Very good morning, all the participants. I'm Saurabh Sandelia, in charge of academics from My Rehab Academy. Today, we are here to learn about trigger point, as you have seen. And our instructor is Dr. Jerrish A. Jose. Before that, I would like to introduce about My Rehab Academy a little more. My Rehab Academy is a platform which connects the physical therapist right from student to professionals to the best of instructors across the globe. And in this due process, we have got far more recognition we were expecting. We got lot many awards, we got lot many recognition, and this has increased our responsibility toward the physio fraternity. Our all the program, whatever you see, every month we have some free program that is only to create awareness, and not just awareness, even our course content is too quality and too highly I can say comprehensive that our instructors we have to request to go for like the kind of free overview program also, so that you can come to know what kind of comprehensive advancements are going on in the field of physiotherapy and healthcare. About Dr. Jerrish A. Jose, I would like to welcome Dr. Jerrish A. Jose today as our resource person. Sir is a PhD scholar. He is certified in ergonomics from Sweden. He is official ex-trainer for EPM International Ergonomics School, Italy. Diploma in facial manipulation levels, all the levels 1, 2, 3 from Italy. Sir is certified dry needler practitioner from Myofascial Seminars, USA. He is presently managing director for Jazz Ergo Physio Center, Bangalore. This Jazz Ergo Physio Center, Bangalore, it is in my city, and I'm very glad that our team has invited Dr. Jerrish A. Jose, who is a well-known name when it comes to ergonomics. And sir is only few of the names in the world who has such comprehensive knowledge, and he is continuing his research, his papers, his all-day activities in ergonomics. So today's part is about trigger point. Sir has a lot of experience and a lot of knowledge about trigger point, and I'm sure that today after the overview course, your idea about the trigger point is going to be totally changed, because this is not 10 years old trigger point what we study in our books or what we see in normal free content or websites. Sir is going to give you the insight which is totally advanced and which is totally scientific and evidence-based. So very warm welcome, Dr. Jerrish A. Jose. It's up to you, sir. Kindly start your content. Thank you so much for joining our invitation. Warm welcome to you on behalf of my whole team, My Rehab Academy.
Thank you, sir, and a very good morning to all the participants. I extend my thanks to My Rehab Academy team members to give me the opportunity to give you an insight on trigger point therapy and how the trigger points are formed and how can you identify and treat these cases. So, brief, he have already shared what I have done. So my interest on trigger point therapy started a long back when I was in 2001, when we found my earlier organization is RECOUP, RECOUP, and I was the co-founder for the physio department, and I was the head of the department and general manager for that, almost 19 years. So where we find a lot of people coming out with early diagnosis. In 2001, it was quite common that somebody comes with neck pain, you call it as cervical spondylosis. When somebody comes with back pain, they say it's a lumbar spondylosis or IVT or something like that. But we realized nothing, there is nothing just blatant classification. There should be something more. We should learn and start working for that. It's almost my experience of 19, 20 years now. So how trigger points are manifested and how are we clinically going to investigate and then design therapy and what are the types of trigger points which you can foresee in this part. So I divided the entire program into two. So that means next 1 hour we are going to see trigger point and its features and how it is being formed. And the other one is about trigger point therapy part also. We'll be going to see that part. So throughout this and our presentation, there will be also questions which you can answer through polls. I have coined some around 6 questions so that in 10 minutes we can have these questions can be answered, so that I know that you are aligned with my presentation or with the topic, that you are able to follow what I am going to explain you with that part. So these are the things, and after an hour session, we will leave for 15-20 minutes specific for question and answers, and then we'll wind up with that part. So this is what the program which I am planning to conduct for the today. So we'll move with the first part. So trigger points, probably you will be familiar with the picture, the lady which is there. She is Janet J. Travel, and she is considered to be the father of trigger points, or we call it trigger point therapy. So that even though she is not the person who can initially say that that's the trigger points which is being identified or something like that, but she has developed immense research programs, designed treatment programs, and all those things for trigger points and treatment. And she was considered as the father for the trigger point and trigger point therapy part. So we'll have first few on the history, like how does this trigger points came? So these people are really familiar with trigger points in 100 years or above? No. So most of these people, when you talk about, when I was talking about 2001 about trigger point therapy to my colleagues and friends, they said, what is that? We have never learned in our UG courses or anything like that. I never heard these things in 15, 20 years back. So she was so keen in getting all those things, and she said that, yes, as a cardiologist and a physician, she was the physician for the John F. Kennedy, so the American president. And she developed this interest that, okay, there is something more, these muscle pain and related problems can happen with that. So even she identified one of these trigger points between fourth and fifth rib, which can mimic cardiac angina. So she has worked as a physician, but she has worked as a cardiologist also in different hospitals at that time. And she's, the significance what she developed, that she has people coming with chest pain. And she was thinking, why people get a chest pain and you get ECG normal, you get your other tests normal. So why are this? Is this really a cardiac symptom? No. So there are trigger points which can typically mimic this angina kind of symptoms. So that's what the extent which she's developed her research to do that part. So as a cardiologist, she was much interested. The early papers and research were developed by Kellgren, and he was working with different muscles, pain patterns and all. And she realized Kellgren was doing something, and where she developed that interest, and she realized to do a little more work on that part. Then she started working on points and all, and the entire medical faculty has given her name at that time as Muscle Queen. So she has changed from a cardiologist, a physician, to an entire differently program called Muscle Queen, where she started mapping these trigger points and parts in the body where these things are being present and seen that part. So she coined, I just put one word because this is something which is quite evident now, because at that time, physicians doesn't see as the patient as a whole. Patient with then trigger points will have multiple problems. We'll have sensory motor and autonomic problems and all those things. But physicians, what they do is that if you have any other sensory issues, they refer you to somebody else, because that's a time where specialties was coming in. So your GP will be referring to a specialist, and specialists will be referring that it is not in my field, you go to somewhere else. So unless you don't see them with a full approach, like mind-body approach, complete part, you will not be able to cure them completely. So trigger point therapy, yes, that's one part, but when you learn trigger points indeed, you know that there are a lot of other areas where it is getting affected, and that's why you require a multidisciplinary team to address these kind of issues part. So on the left, you can see a picture where you have Janet J. Travel, and along with her is David Simons. So he is one of the co-authors for the manuals developed by both of them, which is considered to be our Bible for this trigger point therapy part. So they have two volumes, volume 1 and 2, and it completely explains what are the trigger points, how it is being formed, and where you should be looking for these points in part. So they were the first to publish a 100% as a trigger point manual, and that develops worldwide interest for clinicians and people to do research on trigger points and come up with their findings. So in 2014, when there was an MyPain seminars and other scientific group, they were saying that one of the published manuals, which is almost 70, 80 years back now, is now getting outdated because there are a lot of new research and publications coming. And they said that probably a new manual may be required in the future to talk about in detail about the present trigger point and other related problems along with that. So we asked, is there any other people who have done study before Janet J. Travel? Yes, we have mainly the physicians and doctors from Germany who have developed interest in that part. And they have said that probably a German physician who has started nodules and bands require more than a cursory examination. So this is one of the papers which he has submitted in May 1912. And the importance of muscle tempering in general practice by Washner. And there was also a book written on the muscle hardness, which is called Myofascial, which is supposed to be the cursory manual or the starting manual of first published book on trigger points part in May 1931. So Travel and Simons, when they published it, they have taken inputs from all these people, and they find that, okay, we should coin a better trigger point manual. And that's how they developed with this part. So this, we talk about a brief history of trigger points, how it is formed, and now we are going to say that detail about trigger points. Now, what is a trigger point? How can you define a trigger point? It's a hyper-irritable spot, usually within a broad band of musculoskeletal muscles and muscle fascia. The spot is painful on compression and give rise to referred pain, tenderness, autonomic phenomena. So these are the few parts, but still when we go in detail, you see that what all a trigger point can do. So if somebody asks, well, I said we attended a session, so what is a trigger point? Can you define it? And this is the standard definition by 1983 when they have these books in place. So this was called, if somebody said define trigger point, this is something which you need to write. So it's a hyper-irritable spot with a hard musculoskeletal fissure, and the spot is painful while compression and can give rise to characteristic phenomena like referred pain, tenderness, and even autonomic phenomena. Now, if you ask me, how is this trigger point formed? So the central trigger point develops almost directly in the center of the muscle fibers. So where the motor and the plate meets. So you know this, I think you're familiar with neuromuscular junction in MJ Park. So where these your nerve innervations get into the muscle fibers. So most of these trigger points, when you look for these trigger points, you can see it mostly at the place of where this NMJ meets. So there's where the motor end plate happens for that. So then that we call it as a central trigger point. But that's not only thing. So people say, I just looked for a point, I got it, but it may not. A person will be having multiple points. It can be a different area points, and you have to look for what is the preferred area trigger points which can lead to that. So a lot of things which you'll be seeing that. That's in general. So this is a central point, and where you usually see is towards to the neuromuscular junction and motor end plate meets to the neuromuscular part. Now, what is the science? Somebody asks you, if a layman asks you, how is a trigger point formed? You can simply say that when you are working or when you're doing a muscle overload, you move into aerobic respiration to anaerobic respiration. When you muscle keep working, you end up with acidosis inside, that is getting lactic acid produced. And this lactic acid get accumulated and in turn produces the trigger point. This is something which you can explain to a patient. But as a therapist, you should be knowing what are the actual chemical activities in part. So I'll be just not going too much technical into it, but I'll just give you a cursory overview of that. So he says that the dysfunctional end plate activity occurs, causing excessive release of acetylcholine at the synapse, often associated with excessive calcium. Now, the presence of high calcium level apparently keeps the calcium channel gates open for a longer period of time. And acetylcholine continues to be released further, And now there is a condition called ischemia happening inside the tissues. So the consequent ischemia involves the oxygen nutrient deficient leading to an ATP crisis, and there is a lack of ATP at that area. So you have ATP depletion. Normal ATP already been used, and you have no further ATPs, and then you go a reduced ATP will produce tissues to unable to move the calcium ions out of the tissues. So you will have those calcium gates open for a long period, and your calcium ions cannot be removed from the tissues. Again, the further release of ACH or acetylcholine continues further, leading to a contracture stage. Now, what happens in this state? Actin, myosin, fiber, filament. So usually, you know, this muscle gliding pattern when the muscle contracts and relaxes. So the actin, myosin, filaments slide each other. But here, what happens when you have all these phenomena happening? There is a shortening of the sarcomere. That is called a knot. So once the sarcomere is shortened, it goes to an condition called a knot inside the muscles. So somebody says, yes, trigger points can be felt like a knot kind of things. Yes, so there is a sarcomere shortening with that knot. Now, the remaining parts of the sarcomere are stretched, thereby creating a palpable taut band, which is a common characteristic of a trigger point. So now we already have a knot inside, and the remaining part of the sarcomere is already being stretched, and it can be felt like a knot. So that is where we can call it like a taut band or something which can be kept apart. So going back to what I have told about, you have a dysfunctional end plate, you have increase of calcium levels apparently increasing that, you have acetylcholine being released, you have an ischemia produced there. This ischemia produces what happens that ATP will be utilized all the area. Inadequate ATP will be there part. This inadequate ATP will produce in calcium channel ions there. Then you have an excess release of again calcium acetylcholine, which leads to actin myosin fiber gliding problems, which tightens the sarcomere, or the sarcomere got shortened, then we get a knot inside the muscles. The remaining part is stretched, and we get a taut band inside that. So this is where we can simply explain how a trigger point is formed inside the muscles. Okay, so now I will release for the first question.
Yes, sir.
Yeah, so I'll just stop the screen sharing.
Yes, sir.
Okay, so how do you want to release the question? So you can give the first question to them.
So question is in the screen, sir.
Okay. Who is considered as the father of trigger point therapy? So today I have designed, most of them are very, very, very simple questions so that it's not any rocket science. Anybody who just listened this can answer all those things. So we just leave for a minute to answer. That should be okay. 1 minute is enough, right?
Yes, sir. Yes, sir. Another 10 seconds.
Yeah.
Yes, sir. So can we end the poll, sir?
Yeah, you can end the poll.
Yes.
So, as you all say, yeah. So the answer is Janet J. Travel, because even Simon is a co-author for the book, and their research and the interest for developing these things was developed by Travel. So she is considered to be the father or main part of that. Calagren, yes, she has referred those details from Calagren, agreed, but it's not the Calagren who have done our extensive study on trigger point therapy and research and all those things, and leading to publishing books and all those things. But so the answer is okay, so I'll just go back to my screen sharing. Yeah, so now once we move from how the trigger points is formed, Now, this is pictorial representation of what we have discussed till now. The blue one is the motor nerve part, and where you have NMJ, where this get nerve end plates into the motor end plate part. So MEP is and motor end plates. You have now contraction knots. You can see a bundle getting expanded, and it is like a knot which is already formed. And you have motor nerves and neurovascular bundle, and you have sensory and nociceptive fibers with that. Below you see NMF is a normal muscle fiber. So a normal muscle fiber should be like this. A trigger point inside a muscle fiber should be something which is being already explained to you like a bundle, like a part. Now the question, what to look for this trigger points? So I just give one example to that, because there are a lot of referred pain patterns, and there are in detail about superficial and deep and all. So we'll design a module where we can get into all these things and learn very well with that. So give an example. You have given an infraspinatus muscle as an example. So a point in an infraspinatus, but the patient complains to you, never comes and says, sir, I have a point in an infraspinatus. No patient will come and tell like that. So they will have a referred pain somewhere towards the shoulder, to the anterior, or to the posterior side of the shoulder. And then you also have the other autonomic phenomena like cold fingers, paresthesia, you have numbness. Yes, all these things can be done. So it is something which you look for the trigger points, not by the muscle or anything. It is mainly from the signs and symptoms which they say, and then you relate where you are going to see that part. So it is easier to palpate trigger points in the arm or leg muscles, because that's pretty good, because you can stretch those muscles. Imagine that you have to stretch your some other like spinning, and it's very difficult. So you have to make him lie down, stretch it, and those things are tough. But your arms and stretch is fine, because where you can have with the moment you start stretching your muscles, then you may get these trigger points getting triggered, or may develop this pain with that. So the pain at the end of a restricted range of motion can be also from a trigger point, so that it's much easy if you ask them to do a shoulder extension or a shoulder abduction, and then you find out that yes, these are some muscles which can cause trigger points. Now, somebody asks, is there an way to assess this trigger point? Because most of the time, sorry, one second. So most of the time, when these trigger points have been diagnosed, they say, yes, it is a clinical diagnosis. So how will you objectively update it that, okay, this is something as a valid document that there is a trigger point present in the muscle? So when we say that there is a trigger point, the patient says without an X-ray or MRI, how will you say that a trigger point is present in my muscle? So in those cases, we have magnetic resonance elastography. It is mainly used in research and publications where we can say that this is a shape of a muscle with a trigger point present on that. So here you can see chevron-shaped wave propagation was recorded in a finite element simulation of the wave fronts in the taut band. So when a taut band is being done with an MR elastography, so this is the picture which has been done. Now this is an reconstructed stiffness image of same MR elastography, where you can see there the model filaments were the changes in these bundles is being noted, and the shape, because showing central band region with outstanding stiffness is being detected in these kind of pictures for documentation purposes. So now I hope you know what is MPS, right? MPS is a condition called myofascial pain syndrome. In myofascial pain syndrome, 80% there are chances you get to see a trigger point inside that. So that's why one of the MPS patient, the muscle fibers, this is what the changes inside with that. Here, it is a normal person's with a normal muscle fiber. So you can see the changes in muscle fibers is a typical indication of a trigger point, and that's a valid document which you can represent it. Now, if there is an option of a musculoskeletal ultrasound, so here, now when we have an ultrasound, you can see hypotonic appearance of trigger points inside the muscles, Also, the focal decrease in color variance indication localized stiffer region inside. So this is a normal. This is abnormal. This is normal. This is abnormal. So you can see these variations. So here, that's how this is taken from an upper trapezius muscle, which is most common place where you can do a trigger point. So even if you go to a normal person, you press their trapezius, they may be having a trigger point over there. I'll explain how will you say a normal person you press, you get a trigger point. We'll explain that. That will come on when you get into the trigger point and treatment part. Now, I have attended JP Shah's class when he was in India. He is doing an extensive study in trigger points and identification of the trigger point. In fact, he have developed a lab model. It is not for sale or anything. What he showed me is that he has developed an instrument which detects the excessive accumulation of the chemicals inside the body. So that means when you go through a muscle fiber, he has a small device. He just drags it to your muscle fibers, and some areas it starts beeping. So when I asked him, how do you know that there's a chance of trigger point there? So he says there are research publications when you know that there are chemicals like prostaglandin, bradykinin, and all those your kinins and all those things are getting accumulated more towards the trigger point area. So this will help them that, okay, we can find a trigger point towards more to the active muscle area part. So this is a valid publication done by JP Shah, but biochemical changes also applies to that part. Now, when you talk about investigations, you have electromyographic demonstration, which on electrical activities on active local tender nodules on a taut band. So especially when you put a needle inside a taut band, you get local pitch response. That is something which we can do. But when you have an electromyographic demonstration in wave changes, you can see it when you enter a local focal part. Now, not only that, so not only needle electromyography, there are ultrasound imaging, which we have already shown, IR spectroscopy, MR elastography pictures, we have already seen that. Even a surface electromyography can help in identifying the trigger points inside that. So this is how the investigations can happen and help you with that. So I think it's another 10 minutes over. So shall we move to the second question?
Yes, sir. One second.
So knot is formed inside the muscle because of, you have 4 choices. And in this choice, I want you to select the most apt answer. You may look like most of them are useful, but the most apt answer will be the one which you need to be checked here for. Yeah, so that should be okay.
Yeah. Yes, sir. Once.
So the right answer here is sarcomere shortening. Because even though you know that we have actin myosin fiber gliding, normal gliding happens, but there is a problem with the gliding because of excessive release of calcium, acetylcholine, and ATP utilization depreciates, but the actual knot happens because of shortening. So the sarcomere shortening is the major reason to feel the knot inside the muscle. Now moving back where we have stopped. Okay. Now there are few other investigations which can lead to the presence of trigger points, or which can be a part of your myofascial pain syndrome. So the one thing is a normal blood investigations. People with have hyper or hypothyroidism, they can have a lot of musculoskeletal pain. So somebody which you keep treating with trigger points, and after 6 months, the patient comes back to you and saying that, sir, my points are still there. So then you should do something else is maybe relating with that. Sometimes an X-ray shows a cervical rib. So when people who have a cervical rib, they have more higher chances of conditions like thoracic outlets. Now, ultrasound scans, tendinitis or anything which you are missing, and we pick up with ultrasound scan. MRI, so you have false positive. That means there are research publications stating that people with a low back pain, MRI takes and say that you have a disc collapse. But if you sponsor a non-back pain 100 people, about 40 years or about 35 years, you take an MRI, you will have 60 to 70% of them with a mild disc collapse. So it's not that everybody who have a disc collapse will have a back pain. So you can have false positives because of that part also. No conduction test, not a foolproof system, because sometimes you may get a compression at you have double crush syndromes, you have occurred about cubital tunnel syndromes and all those things where you have nerves are getting entrapped because of this tightness in the muscles and all those things part. So then also you will have a nerve conduction test positive. Now bone tensiometry, yes, osteoporosis, that is something. When you people who have osteoporosis, they all have musculoskeletal pain associated with them. Now the prevalence. So when you take about chronic pain cases, so 85% patients have MPS. And that 4 major muscles are the main culprits when they take the MPS part. One is trapezius, levator, scapulae, infraspinatus, and scaleus. And in that, trapezius accounts for 34%, which is coming in repeated part. Now, in musculoskeletal pain in general, estimated to have prevalence rate of 20% in Canadian study. And one of our study were in our recoup, which we had done in earlier. So you have MPS, myofascial pain syndrome, is a commonly affected part when you take about any musculoskeletal disorders, especially in computer users. We have 49.20%. So that is the extent of MPS in a computer profession. So especially a city like Bangalore. If you take a third person, he is an IT guy. So here, when they say that is a computer-based problems, he always ends up with a myofascial pain syndrome. And in that you have 49.2% prevalence of that. So we have a great opportunity to work with patients to get rid of this trigger points. So the manifestations of trigger points where we see is pain in tension headaches, low back syndromes, pelvic pain, all these things has been published and validated by Travel and Simon's part. Now, people ask me when we have been training a lot of therapists with me, how much pressure I should press to identify a trigger point or an as with that. So there are research publications with algometer, the pressure meter, and we have come up to say that when it is between 2 kg to 6 kg, it is in between these two, you see the pressure variations part. So if you take it in kg per centimeter square, so it starts from 0.8 to 1.8. That will be the centimeter square pressure required with that. Why there is a variation? Because superficial muscles may require lesser, deeper muscles may require a higher pressure. So these are the areas where we look and how you can gauge your trigger point part. It's not that you stand on a patient or put your knee to one of the buttocks and keep pressing and then everybody will have pain. I have seen patients being treated by a trigger point therapist and there is a huge swelling because they applied a lot of pressure which is not required. Now, it's not only that, it also depends upon the muscle bulk of the patient. Even if you are doing a small superficial muscle with a very gym person or very well-built person, you may require more pressure. Or somebody which is very thin and you hardly get any muscle fibers and you apply with like 3 kg, 4 kg, or you applied like 1.5 kg centimeter square on pressure on them because research publications are told like that. No, it's not. So there is a lot of variations in applying the pressure. So you need a practical approach to see what is the actual pressure and diagnosing part. So now moving to the diagnosis, we'll rule out all possible medical conditions. That means differential diagnosis. I'll explain one or two on differential diagnosis. Check for trigger points, palpation, swelling, warmth, or look for some specific tests like Bruce test. You know, this thoracic outlet syndrome, Bruce test part, which we basically do. You have Adson's test, which you look for first rib and presence of that. Now moving to the differential diagnosis, the major one is the fibromyalgia. So you know what is myofascial pain syndrome, and I believe you know what is fibromyalgia is. So you will not get the same clinical features in MPS and fibromyalgia. So in MPS, you will be having a trigger point, but in fibromyalgia, if you're looking for a trigger points, you will never get those things because all are tender points. Wherever you touch the patient will have pain. So it is your discretion to design that. Okay, this is something which I treat with trigger points. This is something which I requires other myotherapy treatment techniques to address those kind of conditions. But now, in differential diagnosis and treatments, delayed onset in muscle seen in accustomed and eccentric muscle exercises, post-laminectomy and failed spinal fusions, connective tissue disorders like hyperflexibility of the joint and hypothyroidism, vitamin B12 deficiencies. All these things can be part of differential diagnosis also. Infectious diseases like Lyme disease, drug-induced myalgia, encephalomyelitis, chronic fatigue syndrome. This is mainly seen in fibromyalgia. You will hardly see it in myofascial pain syndrome. Neurogenic myalgia and radiculopathy in nerve entrapment, where it is actually your grade 3 disc collapse and we are looking for trigger points. No, that's wrong. So viscosomatic pain syndromes, even people with the back pain I've seen, they keep looking for trigger points, but the patient is having a TB spine. And so it's a differential diagnosis. So you should be 100% sure it is arising from the muscles and part. So what are yellow flags and red flags in trigger point treatment point? The yellow flags, most of them will have psychosocial factors, which leads to your trigger points, formation of these trigger points. Red flags, very serious concomitant musculoskeletal pathologies like fractures, neurological deficits, malignancies, and infections. All these comes under the red flag formation. Now, manifestations of trigger points where we have intermittent claudications. So here you know that the calf muscles and these things can create intermittent claudications. That means when you have people there, when they exercise kind of vigorously, they suddenly get some cramping kind of pain and all those things throughout the leg. And this comes under the part of intermittent claudications. Bursitis, arthritis, tendinitis, and muscle tears. Yes, it is a manifestation of trigger points. Knowledge of trigger point referral patterns in essentially is very much important in evaluation of a patient part. So that means you need more of practical part in getting these things done. Now, when you talk about upper trapezius, so it is most common involved in posterolateral neck pain, temporal headache of the same side. Now, it is not only that, they can also create an jaw pain at the angle of the jaw. So when you have a trapezius point, these are the things which you can look for. An active upper trapezius with additional involvement of levator scapula. So most of them say when you have a trapezius point, there means associated muscles are also a part of it. That means you have to look for levator scapulae, splenius cervicis, because these can develop an acute stiffening with all these combinations of parts. So that's why when a trigger point, you cannot just say A and you say, I'm going to treat only A. But this A can relate to B, C, and unless you don't treat B and C, you will not get a result as a whole. Now, what are the phenomena which you should be looking for when you treat the third part? The first one, when you have a sensory phenomenon. So we have major 3-1. You have a sensory phenomenon, we have a motor phenomenon, then we have an autonomic phenomenon. So in sensory phenomena, the pain in MPS may vary from intermittent mild ache to ever-present or excruciating. Some days patient has no pain at all. On 4th day, patient says, oh my God, I cannot hold the pain. It is so bad. So then you should not be scared that, oh, what is happening with the patient? Am I doing something wrong, or is the condition itself is wrong or anything? No. The sensation of localized pain can be attributed to damaged muscle membranes. Also, there is an increased release of serotonin, histamine, kinins, and prostaglandins to sensitize the nociceptors. So that's why when I said about J. Shah, when he was doing those instruments to find these trigger points and all, this is the chemical release, and this can irritate your sensitized nociceptors. Somebody says, when I sit below the fan, I feel burning sensation. Do you think it's a normal? Actually, people may think the person is psychic. They say, I have patients coming to me and saying that I cannot wear a shirt. Wearing a shirt, the rubbing of the shirt creates the pain. Yes, so where you can have these sensory phenomena because of that part. In motor phenomena, the presence of taut bands and trigger points can result in decreased range of motion, weakness, and muscle imbalances. So which we all know how to look for motor phenomena. Now, what are the autonomic phenomena which you can look for is excessive lacrimation, motor activity, excessive sweating, redness around the trigger point area, distorted proprioception, local edema, and autonomic effect zones are not necessarily the same as the pain referral zones. So there are more autonomic phenomena, but these are the few which I can name, and you can look for whether these autonomic phenomena are seen with that part. Now, the instruction, you have asymmetry of posture, restriction of active and passive range of motions, and abnormal movement pattern as a result of myofascial pain tightness. Before we move to the palpation and to the trigger point therapy, we'll move to the next question.
Yes, sir.
Now, NPS percentage in computer users, according to the research done by Sharon et al., that is our report which we done in 2009, what percentage is what it is being seen with?
Okay, sir. So can we end the poll?
Yeah, we can end the poll. Good. So the answer is 49.20%, since we already explained, because NPS in computer users is something really significant. And 49.20% is the findings which we had for NPS. Now, palpations. So now this is quite important in trigger point, because if you don't palpate, you will not be able to feel the trigger point at all. Now, for that, the muscle should be relaxed. The problem is, as long as the spasm is involved, you heard about this cycle called pain, spasm, pain, spasm. That means when there is a pain, you will have an underlying spasm. When there is a more spasm, it will create more pain. When there is more pain, there will be more spasm. So you will not be able to really help the patient with that. So first, you need to relax the patient. For that, you can use neuromuscular techniques. You can mildly stretch it or use an MET. There are a lot of things which we can discuss and do that part. Once it is relaxed, then you can go for the palpation part. Now, once the palpation is the key, so now you have to look for some signs and symptoms when you do the palpate on a trigger point. One is hot tenderness, palpable band, local twitch, jump sign, and patient recognition. So these are the things which we look for. Now, what are the methods of palpations? We have 4 types of palpations. We call it as flat palpations. Flat palpation, that means your finger flat and looking for those spasms in the superficial tenderness and the muscle tone part. Now, fingertip palpations, where you have muscle fibers, you look for taut bands and tender points on that to look for that part. Then you have a pincer palpation, especially like trapezius and all, you can easily do the pincer palpations. So the thumb and you can do that part. So pectoralis major and all is a typical example for that. Overlying hand palpations, that's mainly which we use for the deep muscles like piriformis or more deeper gluteal muscles and all those things part. So these are the 4 palpation techniques which you can use for that part. Now, what are the clinical features of a trigger point? It's like we have 6 points which we are going to explain about the clinical features. So the first point here is taut band. The taut band, which we know that when you put a needle or when you try to press on that, or we can see that the local tenderness, a band-like formations seen on that part. Now, after the taut band, we have the next one is spot tenderness. So when we do this trigger point therapy, or when you try to put a fingertip to the muscle and you can feel a knot kind of sensation or a spot tenderness over that muscles, that is a typical clinical signs for a spot tenderness activity. So we have a taut band, you have a spot tenderness. Third one is a jump sign. You all know when you accidentally press on the trigger point, patient jumps. So that is a jump sign part. So where when examiner is exactly on that point, that can produce a spontaneous exclamation of the movement, which is called as jump sign. Now, fourth one is pain recognition. That means when you are on an active trigger point, I specifically said active trigger point, there is always a pain recognition happening over there. So when you are on the active trigger point and you try to palpate it, or when you try to press that point, there will be always a pain recognition on the point. Twitch response, when you try to needle it, when you try to release that, you can see the muscle is twitching. So that is a typical sign for the point. We talked about taut band, we talked about spot tenderness, we talked about jump sign, we talked about pain recognition, we talked about twitch response. This is called a local twitch response for an SCM, sternocleidomastoid, where we try to palpate the SCM, where we try to release that. You can see the muscle is getting twitched, and you can see the borders of the muscle more clearly when you try to do the trigger point release for that part. Now, the next one is mainly we talk about pain, referred pain, and tenderness part. So 85% of the reported pain patterns project distally. So when you do a proximal point, the pain are referred distally. It's not that every point will be always referred distally. It can be to some other area also. So there are research findings when they try to do an injection or a needle, the referred pain persists for a day or two. So that means if you do an infraspinatus needling, and the pain may not be on the needle side, the pain may be on the shoulder. That's the referred pain part, which we can see that. Now I have taken up all these things to see that what is the clinical features which you can see on a myofascial trigger point. So your examination on this side, and the middle you can see difficulty in doing that, and diagnostic value. So what are the diagnostic values in doing that? So here the first is spot tenderness. You have 2 points for the diagnostic value, and difficulty is very, very less. Jump sign is also difficulty is very, very less. Diagnostic value is just 1. Pain recognition, its diagnostic value has much higher value. Palpable band is most higher value, and you have a bit of difficulty because you may not be able to see that whether it is a palpable band or whether it is a muscle tendon. Early people who palpate, they say it can be a muscle tendon, it can be a band. So you need to start working on these patients, and then to start recognizing what is palpable band. Referred pain, you have difficulty using 3, and then diagnostic value is 1. Word twitch response, pretty good. So you have to look for a twitch response, local twitch response, that has a both diagnostic value and difficulty part. So all these 6 is the clinical features of a myofascial trigger points part. Now when you ask me, what are the types of trigger points which you can look for, or what are the different types of trigger points are present? We have 4 types of trigger points. So people only know 1 trigger point, but actually there are 4 trigger points. It's called active trigger point, latent trigger point, key trigger point, and satellite trigger points. So what is an active trigger point? It causes pain and tenderness at rest or with motion. It prevents a full lengthening of the muscle as well as fatigue and decreased strength. Now, once you are the pressure on the active trigger point, the main thing which you have to look is whether it reproduces the signs and symptoms the patient is complaining. Suppose I'm saying I'm having a shoulder pain. There may be a radiating pain down also. I have some numbness in hands. So all these signs and symptoms I'm talking about. If I am a trigger point therapist, I know where it is coming from. I accidentally press the infraspinatus muscle. And the patient says, yeah, it is feeling a bit numb. I feel a lot of pain in my shoulder. So when these clinical signs are reproduced, that's where when you know that the active trigger points are there. Now when you talk about latent trigger points, so the points which causing normal doesn't happens in a normal muscle movement or anything kind of part. So these are basically silent. They are not really active. But when you go and search for this trigger point, when you press on that point, it may have pain. The signaling of the latent trigger point is that whenever this active trigger points disappears, then chances of latent trigger points to appear is higher. So it's not that the first day you should be searching for a latent trigger point. You basically address the active trigger points. But when patient comes and say that, sir, you treated my right neck, but my left neck is paining. So that means the right neck, when you treated, the trigger points should have been better. But the latent trigger points on the left leg has triggered after a week or 10 days apart. Now, what is the key trigger point? So it is responding to activating one or more satellite trigger points. So it's developed almost directly in the center of the muscle fibers, where the motor end plate innervates in and at the neuromuscular junction. So it is mainly activating satellite trigger points is what is the pre-trigger point activity. So what is a satellite trigger point? It develops in a zone of referred pain pattern of the key trigger point part. So it may not be on the main trigger point area, but it will be happening on the referred area part. So somebody says that I have pain on my trapezius, and you have a referred pain towards to the neck or towards the jaw. Then you realize you have an SCM or the upper part where you have another trigger point involved on a part where it's a satellite trigger point which can radiating this pain to that part. So that is where we have these things. So now before we move to the last part where we trigger point therapy, we will go for the next.
Oh, okay, sir.
Now, how many clinical features you can look for a myofascial trigger point? We just talked about it, and it's very important when you go for a trigger point therapy part. So if you remember the table, the plus and those plus points, 1 plus 4 plus and all. So if you know how many factors we discussed, that will be the right one for to answer this question.
So can we stop there?
Yeah, we can do it. So the answer is 6. 6 is the right answer. So people who have been doing 4, that means they have short-term memory loss, right? Okay, now so why I said because we have a table and we have been discussing that table. I'll just show you that. Yeah, you can see we have 6: spot tenderness, jump sign, pain recognition, palpable band, referred pain, and twitch response. So these are the 6 points which we look for a clinical features part. And that's what we look. Okay, now going back to treatment. So there are 2 techniques which we apply in trigger point treatment part. One is called ischemic compression release, and the last one, which is the other way which we do, is called and deep compression movement across the muscle. So that we call it as a cross-frictional massage also. So these are the 2 ways which we do it. So for an ischemic compression technique, locate the point and apply pressure directly on it using the finger pads. So we have 4 types of palpations for that. You can use all the 4 also for ischemic compressions. Now, amount of pressure judged by looking at the blushing of the nail bed. So now, if you don't have an algometer, somebody asks you, how much pressure should I apply? The best one is that when you press, you need the nail bed, right? You know your nail bed is here. So when you have a nail bed, when you press on the nail bed, when you see the blood flushing in to the nail bed, maybe that is something like your judging point. Now, how many seconds you should be holding it? 90 seconds. Or to a maximum of 120 seconds. Don't do that more than that. If you are doing more than that, there is something wrong. So mark the pain scale before the treatment starts. Monitor the pain scale throughout the treatment. So what is a common pain scale which you use? Visual analog scale, 0 to 10. Or if you want to shorten it, 0 to 5. That should be fine. the pain comes down and the point starts to resolve. This is with an ischemic compression release. Now, how does it work? How does this ischemic compression work? The theory states that by binding ischemic compression to the trigger points, we are trying to suffocate the point with deprivation of the oxygen supply. And due to this ischemia, the point dies off and then you start getting relief the pain. So you're trying a local inflammation or ischemia there, and that helps in tissue remodeling and getting the vascular system flushed into there, and then it washes out your metabolic waste products kind of thing, or probably it gets remodeling of the tissue. So these are the things happening when you do an ischemic compression, and then how does it work with that part. Now, what are the drawbacks in ischemic compression? It's not very effective when applied to deep trigger points. It is not very effective in case of chronic trigger points. Also, chance of reappearance of trigger points are more in this method. So people have come back to us after 5 days or 10 days. Sir, I still have some amount of pain. So probably ischemic compression may not be the only thing which can be done for them. We may look for the second technique, that is called a cross-frictional massage or a deep compression moving across the muscle fibers. That is something which is more effective with that part. Now, there are some areas where we can use ischemic compression. That is like very short time is required. You need to do some results, or the point is very, very, very tender. The patient is not allowing you to do any deep friction movement or anything. So you can use an ischemic compression, and because it produces less of soreness and give you an immediate pain relief. So benefits are also there, but the results are not so deep or not so long lasting. So we always prefer the second one to do that part. So before we move to the second one, we'll have the next question also. Somebody, can you share the next one?
Yes, sir. Yes.
So it's quite simple. How many types of trigger points are there? I think those who have listened to my just class just few minutes back, everybody should know what is a common point. So I have designed the questions as simple as possible.
Okay, so can we end the poll, sir?
Yeah, we can end the poll. Good. So the answer is 4, because that's pretty simple, straightforward. 4 points we talked about. We talked about active trigger points. We talked about latent trigger points. We talked about key trigger points and a satellite trigger point. These are the 4 trigger points which we talked, and that's where our answer is. Now we go back to our screen. So now the next technique is deep compression movement across the muscle fibers or cross-frictional massage. So this is applying, first thing is locating the trigger point. When the trigger point is located, apply a deep compression over there. We already discussed about what is the pressure required, where you have seen that nail bud is flushing in. And when that is there, then the movement is across the muscle fibers. And now you have to, again, the thing is that you have to look for the response from the patient. So that means, what is the pain? So when we started, the pain started at 8. Then when we taking about around 90 seconds to 120 seconds, the pain is coming down to somewhere around 3 or 4. That seems to be the significant thing which you need to look for doing that part. So that's how you do a cross-frictional massage or the treatment for that part. Now the drawbacks, where you have more swelling, chance of swelling is higher, because you have a lot of pressure being applied because of movement across the muscle fibers, and not possible in very tender points where patient don't allow you to touch in that part. It takes more effort from the therapist. Yes, I agree that. Being 20 years working in the trigger point, I myself get some trigger points and get my son to treat me whenever I get some time from him, bribing him from chocolates and getting the treatment done. Now, the direction of the muscle fiber should be known. So if you are not sure about the trigger point, you keep circulating it, you moving around and all, then you end up with a lot of soreness. So when I've seen people doing trigger point therapy in a circular movement and all, the problem is you have more chance of soreness, swelling, and redness, and all those things. The benefits, it's applicable in case of deep trigger points also, very useful in case of chronic trigger points. Long-lasting results, better than ischemic compression release and all those things. Now, what are those adjuvants which you can use along with the trigger point therapy part? So where we have ultrasound, we have, after the treatment, we can try that, or during the treatment, we can have MET, positional release technique. You have INIT, integrated neuromuscular inhibition technique. So we have a myotherapy program where we be explaining about all those techniques which can be done. So when we think about what are the muscle treatment, when in myotherapy means treating with the muscle, what are the techniques which you can use? We have a lot of things. We have MFR, different types of MFR, so many things which we can do that part. So individual muscle stretches, hot or cold packs, depending upon, or you have a contrast bath, where you can have these hot and cold alternatives and all those things, which can apply as an adjuvant to a trigger point therapy. Now we move to the last part where we have assumptions that when patients are being treated, what a therapist should be taking apart. Utilizing the feedback from the patient's body, asymmetrical soft tissue tightness and restrictions can cause pain proximal or distal to the area of the actual dysfunction. So that it's quite natural that when you treat one area, the other area gets pain. Because you're treating and releasing one side, there will be an imbalance in the other side which can create the pain. Or patients will talk to you saying that, or they may come back and saying that my pain is traveling. Doctor, you treated my neck, I have my back pain is paining now. So you have to explain them why these things when you release one side. So probably you are aware of upper cross syndromes, lower cross syndromes and all. So if you treat one area, the other areas will get part. Now you have trigger points can pain radiations like facial pain. So since I have done all the level 3s of facial manipulation, including the level 3 where they talk about viscera and generated pain from their part. So there are a lot of correlations between trigger point pain and the facial pain and all those things part. So you tend to mistake this is from the fascia or this is from the trigger point and all those things. So you should have a clear-cut demarcations with clinical signs, symptoms, and all those things for that point. Now, some therapists, early trigger point therapists says, they've been treating a point for 2 minutes or 3 minutes, and the pain is not coming down. So that means you are not on a trigger point. If you feel like a knot, it may not be always the knot which you are feeling, especially in the neck and those areas. You will have a lot of lymph nodes. And if you are not sure on the muscle and the tendon and feeling a trigger point, you may be in fact seeing a lymph node, and the next day you get a huge lymph node inflammation. So if you think that your point is not right and it is not responding between 90 to 120 seconds, better stop it and don't do it further in detail and then create a lot of issues on later changes. Now, process of change. That means initially patient may feel more uncomfortable than many experiences, like new pain, and must learn to function in an unfamiliar alignment. So that is quite evident. We have already explained when people are doing that. When you treat one area, you may get other pain. Or people say that I never had my right side paining. You treated my left side and now my entire right side is paining. So these are all because you have experienced a new pain, which is because of the process of the change happening. And some tightness may be evident when the other area you get treated with that part. Now it's not only that, people who have been living, imagine that you person with an MPS for 5 years, they have pain on a shoulder and one fine day you treat your shoulder, patient may not be able to take it up that the pain is completely gone. So you may require and more like a neurological re-education and reprogramming for them part. So you heard about phantom limb, right? When you have an amputation and patients may feeling that I still have the limb. So I have a lot of patients, they say, doctor, it takes few days for me to recognize the pain is gone or not. I said, you came to the hospital with pain. It took you 5 days or 10 days or 20 days. And your pain, you said there is no pain at present. Yes, sir, I've been living with this pain for 15 years. And one fine day, 10 days, you say that there is no pain. Right now, I don't have pain, but my brain is not accepting that. So those kind of problems you may come across with when you start treating this part, and then you see that you need to have a neurological re-education for those programs. Now, this here I think we have one more questions.
Okay.
Question, right? I think we'll do that part. So what
Okay.
I'll do, I'll stop screen and then we'll go for the question to answer. So how many seconds does a trigger point require to resolve? Straightforward question.
Okay. Can we?
Yeah, you can end the call.
Yes, sir.
So the answer is 90 to 120 seconds. That's quite evident in most of my slides. I have been explaining you about 90 to 120 seconds is the time frame which you look, the trigger point is getting resolved by the time when you start palpating and releasing them. Now, before I end the session, I know that there is a lot of practical knowledge has to be put into it. There are ways in palpating the superficial muscle, the ways in palpating a deep muscle, and there also we can do a clinical reasoning behind that. So suppose you get a back pain, what are the muscles you should be looking for? Suppose you get an upper cross syndrome, what are the trigger points which you can look for? Where you see the satellite trigger points, where will you see the latent trigger points and all those things parts, where actually you need a hands-on approach for all those things. So I think in discussion with Myofascial Academy, we have designed module 1 and 2, like a 2-day program, where we have a superficial muscle palpations and release of trigger points. Condition in level 2 will have more deeper one with along with condition wise, like neck pain, back pain, headaches, different types of cervicogenic headaches, which are the points which can relate to. Even people have TMJ problems, temporomandibular joint problems and other things. Where are those points which you need to be looked for? When in chronic back pain, there are a lot of points which we look for. So all those problems which we will be seeing and in detail in hands-on palpations, probably in January, I think they will be announcing probably in the program itself. So that we can, after that, then we'll go for the question and answers part.
Yes, sir.
So,
Yes, sir. So just 1 second, sir. Yeah, so please unmute and ask your doubts one by one. What about you? Participants, please please unmute yourself and ask your doubts.
Sumit, is there any questions raised in the chat or something like that?
Yes, sir. So what is the difference between muscle trigger point and facial trigger point? Somebody's asking.
Yes. So yeah. So when you talk about muscle trigger points and facial trigger points, fascia, they will call it as trigger points. So these are called as facial points. And most of these facial points, they say it's a fixed point. You have different planes. It's mainly derived from meridians from the body. You have ante, medial, lateral, retro, all these areas, and they have a fixed points in different parts. Probably they have on temporals, we have on arms, and all those points are fixed. And the release of the fascia is also different. So where the focus is mainly to improve the hyaluronic acid inside and improving the facial function. But and the trigger points, the clinical features, we talked about 6 clinical features. And our signs and symptoms is mainly for getting treated for a referred pain or the direct point pain and other things. So you have a facial and facial manipulation is entirely different when you do this. Now, if you talk about a general facial release, more like an MFR, yes, we can have gross MFR, you have segmental MFR. So probably once we are in our practical session, then we can talk about all those things.
So next question is, why does a referred pain occur?
The referred pain occurs because mainly because the pain patterns from the muscle fibers is been referring to that directions. So probably if you have an infraspinatus, you see that it's going to get attached to the.
What is the trigger point is in the body
I think,
parts?
Sumjit, I think I am answering one by one. So
Please, one by one only answer. Yes.
yeah. So that's where you see the referred pain patterns, more towards its attachment area, or it may be a satellite trigger point present. You will have a more referred pain towards from that area. All those things are the reasons for a referred pain in a trigger point.
Okay. So next, please unmute yourself and ask your doubts. Can participants one by one?
Hello, sir.
Yeah.
So I just wanted to know, like, what all changes should we see in complete blood count, like, which causes repetitive triggers, like you had mentioned.
Yeah. So what happens is that the complete blood count is not a diagnostic criteria for an trigger point therapy, because when we look for complete blood count, we see about ESR is high. So you have chances of inflammatory arthritis, and that can relate with myofascial pain syndromes. So people will have inflammatory arthritis, they will also have associated muscle pain. So when we see a complete blood count, we can have those part, and probably with high uric acid, you have chances of, again, muscle pain with that. When you have TSH level high, yes, you can relate with the muscle pain. Vitamin D deficiencies in blood test, yes, that can relate to a musculoskeletal pain part. So even if you treat a patient with a high vitamin D deficiency, and the patient may come back to you later because the vitamin D itself is creating some amount of back pain, or sorry, the musculoskeletal pain. So if you want an complete release, you need to go and see as a whole why this patient is getting a musculoskeletal pain again and
All right, sir. Thank you. So, can hemoglobin, like less hemoglobin, is always obviously going to cause fatigue and all. So, could that also be one reason?
yeah. So what happens when you have less hemoglobin, when you're anemic, the fatigue and more energy utilization, and that can lead to micro cramps inside the muscles. We talked about the trigger points formation. So chances of trigger point formations are higher because of you have less energy and excessive use of the muscles to perform the activity and all this in part. So yes, so it can also lead to the trigger points in the later stages.
Okay, sir. Thank you.
Yeah.
Okay.
So there is a question.
Hello? Yeah.
There is a question, sir. There is a question.
Yeah.
Yeah, whether electrotherapy is effective for trigger points or not.
Well, you can use it as an adjuvant. So I have already explained about ultrasound has been using as an adjuvant for that part. So we have instrument assisted part. Even I am a certified factor practitioner. So I have a factor instrument which we use it to do a part. So there are a lot of ways which you can use instrument for helping up to get the trigger points relieved. So that is one way as an adjuvant. But basically the knowledge of the trigger points is something which you really need. Satellite points, where to look for, what are the referred areas which we're looking for, how are these being diagnosed and all those things.
Another question is like the gluteal muscles, whether it develops the trigger point, like what could be the causes? Gluteal muscles, the largest muscle.
The gluteal muscles is quite, because you have been overusing your gluteal muscles in sitting and a lot of activities. So people don't walk properly, you have gluteus muscle firing, you have all those issues. So where you have more chances of gluteus medius and all those muscles getting pain. So trigger points are most prominent in that. And not only that, you have post-injection syndromes. So I have patients, they have taken an injection of the gluteal, and after later stages, they develop a lot of pain on the gluteal area because there was a huge trigger point there. So muscles, piriformis muscles, all these are significant area where you look for trigger points when you have people who are constant in sitting and other areas.
This satellite.
Sir,
Satellite.
Can I just
Yeah,
ask a question?
Please ask.
Yeah. So actually, trigger
Hello.
point release. Hello.
Madam.
One by one, please. One by one, please.
Hello.
Yes. Can
How
I
to
say?
use types of trigger points?
Go ahead first, then next.
So,
Hello.
so it is overlapping.
Hello.
Hello, anyone wants to ask question?
Please one
Yes,
by
sir.
one
Yes,
ask.
sir.
Please
Yes, sir.
one
I
by
need to
one.
ask one question, sir.
Yeah.
Sir, which technique will be more effective in treating the trigger point, sir? I think regarding needling or ischemic compression or cross fiction.
So now we have ischemic compression, cross functional, and needling. Now each one has a different part. I myself, as an instructor for my Penn Seminars USA for needling, so needling helps in specific points. I do a mix of all three. When I get more like tender patients, I will never able to do a needling, nor able to do a cross functional massage. Who comes with a lot of tightness in the neck. She walks like this, and she says, "Sir, please don't touch. I'm getting severe pain." You may have a huge point there. You know that you can feel it, the point there, but she may not be able to do that. So the only ischemic compression works for her for first 1 day or 2 days. Once she starts getting eased up, then we can think about cross-functional massage. Or when you know that points are pretty deep, where you don't want your finger to hurt, then you want a needle to be inserted. Yes, then you go for a deep needling part. So all these things can be utilized in different stages of the condition where the patient comes in. So all three is also valid treatment.
Okay. Sir, if we were doing ischemic compression means how many times we want to repeat it, sir, at the same point?
Well, the same point, I think not more than 2 or 3 times, because ischemic compression on the same point get relieved within 2. If it is not, then there is something else.
Okay. Is that dry cupping will help in releasing the trigger point, sir?
Well, no, it is basically you have been squeezing that muscle, and it is basically you're squeezing and holding. Yes, so you will have some amount of relief. If somebody says, I keep pressing and holding this area very tight, then I feel bit relief because of that. But I don't think that is mainly we are able to release that area part. So once the squeeze effect is gone, then part. Even somebody says, I go and take a very hot shower, I feel my muscles are better, like a hot pack which we do. So there are some bit of temporary release. But trigger point release is a pretty, now it is not a temporary program. So if you say, if you do a deep frictional release, you can treat the patients permanently. I have patients who have been pain-free for years after a trigger point release. So it's not that it's just a temporary technique which you try to do and just do it for a few minutes or a day or two to be pain-free. No, this is an active technique which can be used like your normal other treatment modalities where patient can be completely pain-free with it.
Okay, sir. Thanks a lot. So another 2 more questions we can take. 2 more last questions.
Yeah.
Please unmute.
Sir, hello.
Yeah.
Yeah, 2 more questions here, please.
Hello, I'm Dr. Shiva.
Please,
Yeah.
go ahead.
Trigger point contraindications, please.
Well, we have a lot of red flags for trigger points. So somebody who have a TB spine and you think that is a back pain and you start releasing trigger points on the erector spinae and all our areas. In fact, that's a red flag if you do that. Somebody who has any infection below or if you have any fracture stances and you think that it's a trigger point, you keep rubbing and you get into myositis ossificans in that area. So it's not that everything is a trigger point. You should be able to elicit these clinical features from those muscles. That's why the entire session we talked about is getting a right trigger point located and then treat for them. Otherwise, if you even the other contraindication is a lymph node, you think like a knot. You keep rubbing. I have patients coming to me with a and they said I did a trigger point and get a swelling and like a knot kind of big thing here because the lymph node is enlarged because of that. All those things are contraindication.
Okay, next question.
Okay, last question. Anyone?
Hello.
Yeah, please go ahead.
Like in muscles, the mechanism of formation of trigger point is the shortening of sarcomere. So how they are formed in the fascia? What is the mechanism of formation in fascia?
Fascia is nothing to do with sarcomere or anything. Fascia doesn't go to the muscle at all. Fascia, the only thing which they say is that the gliding of the fascia or the web-like structure of the fascia is made of the hyaluronic acid inside that. And once the hyaluronic acid is deficient, it becomes like more sticky. You feel like fascia.
Hello.
And that's the reason which you get these problems. Okay, so fascia is different and muscle trigger point is different.
Okay, sir. So,
So-
what is Dr. Saurav?
Yeah. So it was a brilliant content what you brought today. It was an amazing action, and I can say that the 100% of candidate today, they stuck to the last moment. So that shows the kind of brilliance of your presentation, sir. So thank you so much for such brilliant and amazing interaction. I have a request from CEO, sir. I think he has only permitted me to say, sir, I want you to say that like you are coming for our physical event also, which is going to be in the Bangalore, 23rd and 24th January 2021. So you could book your seat right from today onward. So Jerrish sir will be here to give you much more detailed insight about it. And one more thing, here onward, My Rehab Academy is not just going to go for only physical event. The same physical event will try to stream even live. So there are some terms and conditions for that. You must mail, or you can just go through that and you can find it. So wherever you are there in the world, you can always connect to our pioneer instructors like Jerrish sir, who will be giving you the wonderful insights, as well as who will be letting you go through all deeper theories, evidence-based and quite advanced. So this is what I wanted to let you all know, that Jerrish sir is coming to give his broad lectures on 23rd and 24th with all practical hands-on session in the city of Bangalore. So if you are interested, you can contact to My Rehab Academy, our central number 9066990059. So you can send message on WhatsApp, or you can mail us myrehabacademy@gmail.com. We are always there to answer. And it was wonderful to see Jerrish sir. I think you know that our membership program we had kept open till 31st of October. It was quite free, and more than 1,000 people they joined. So that shows the kind of trust what we have built up. And it was only possible through the pioneer people like you, who always accepted our invitation and made the program much more lucrative and much more interactive than we thought ever. So thank you so much for accepting our invitation and brilliant presentation. See you, sir.
Yeah,
Thanks.
Thanks.
Thank you,
Thanks,
sir.
Samarai, and thanks everybody
Yeah.
for joining.
Thanks a lot.
Thanks a lot.
Thanks a lot.
Thank you, participants. Sir, with your permission, then we can
We can conclude.
wind up
Close it.
today.
Yeah, sure. We can.
Thank you all participants. Thank you.
Thank you, everyone.